topic is drug therapy of angina. So this is part 1 of my video lecture in which I will be talking about angina, the pathophysiology of angina, how to differentiate between different types of angina, the classification of drugs, and in details about the nitrates that are used for the prevention and treatment of angina. So to start with, what is angina? Angina means chest pain and it is a symptom of ischemic heart disease and not a disease. It occurs due to an imbalance between myocardial oxygen supply and myocardial oxygen demand. The figure drawn here shows the pathophysiology of angina or chest pain. Chest pain or angina occurs due to mismatch between myocardial oxygen supply and myocardial oxygen demand. Decreased myocardial oxygen supply can occur due to fixed atherosclerotic narrowing of the coronary arteries, which causes stable angina. Secondly, atherosclerotic plaque rupture, which can cause platelet aggregation and thrombosis and leading to abrupt reduction in the blood supply to the heart, and this can cause chest pain. There can be sudden focal or diffuse vasospasm of a major coronary artery, and this can reduce the blood supply to the heart, causing chest pain or angina. So these conditions decrease the myocardial oxygen supply, causing chest pain or angina. Now there are certain situations where the myocardial oxygen demand increases. For example, when the heart rate increases, so increased heart rate causes increased workload on the heart, increasing the energy consumption and the myocardial oxygen demand. The second condition is increased contractility of the heart. So more forceful is the cardiac contraction, more is the energy consumption, and greater is the oxygen requirement and the myocardial oxygen demand increases. Thirdly, increased preload can also increase the myocardial oxygen demand. So do remember that preload relates to the end diastolic volume or end diastolic pressure or the venous return to the heart. So when the venous return to the heart increases, the end diastolic volume increases, the pressure increases, the ventricular wall stress increases, and this causes increased workload on the heart, increasing the myocardial oxygen demand. The fourth condition is increased afterload on the heart. Do remember that afterload is related to the peripheral vascular resistance. So when the peripheral vascular resistance in the arteries increases, the heart has to work harder to overcome the resistance in the peripheral arteries. So because of increased resistance and increased workload on the heart, the myocardial oxygen demand also increases. So myocardial oxygen demand increases when the heart rate increases, when the contractility of the heart increases, when the preload increases, and increased afterload can also increase the myocardial oxygen demand, leading to chest pain. So how do we differentiate different types of angina? The types of angina can be as follows: stable angina, unstable angina, and vasospastic angina, which is also known as variant angina or Prince-Metal angina. So what is stable angina? Stable angina occurs because of progressive atherosclerotic narrowing of the coronary arteries, and this decreases the blood supply to the heart. Here there is no pain at rest because the blood supply to the heart is adequate to meet the needs of the metabolizing tissues at rest. But when the myocardial oxygen demand increases, for example in situations such as exercise or emotional reaction, so here the workload on the heart increases, the energy consumption increases, and the myocardial oxygen supply is not adequate to meet the demands of the metabolizing tissues. So when the myocardial oxygen demand increases, the patient experiences chest pain, for example during exercise and during emotional reaction. Therefore, in stable angina, beta blockers are the drugs of choice because they decrease the heart rate and contractility, thus decreasing the myocardial oxygen demand and help to relieve chest pain. On the other hand, unstable angina occurs due to abrupt reduction in the blood supply to the heart. This is because of rupture of atherosclerotic plate causing platelet aggregation, thrombosis leading to obstruction of blood supply to the heart. So here the patient experiences pain at rest and does not respond to nitrates. This is because the blood supply to the heart is significantly impaired, and even in the absence of increased myocardial oxygen demand, the patient experiences pain at rest. In unstable angina, we can also observe electrocardiographic changes such as ST segment elevation or depression, which is not observed in stable angina. So what about vasospastic angina or variant angina or Prince-Metal angina? Vasospastic angina, as the name itself is suggestive, it occurs because of focal or diffuse vasospasm of a major coronary artery, thus reducing the blood supply to the heart. Because the normal amount of blood is not delivered to the heart, the patient experiences pain at rest. Here, the patient shows prompt response to nitrates. Next, we can classify anti-anginal drugs as nitrates, beta blockers, calcium channel blockers, potassium channel openers, PFOX inhibitors, and sodium channel blockers. The nitrates include glyceryl trinitrate, also known as nitroglycerine, isosorbide dinitrate, isosorbide mononitrate, erythritol trinitrate, pentaerythritol tetranitrate. The beta blockers include propranolol, atenolol, and metoprolol. The calcium channel blockers include verapamil and deltiazem. Nicorandil is a potassium channel opener. The PFOX inhibitors include trimetazidine and ranolazine. The sodium channel blockers are ranolazine and ivabradine. So let's now discuss the pharmacology of nitrates. The nitrates include glyceryl trinitrate or nitroglycerine, isosorbide dinitrate, isosorbide mononitrate, erythritol trinitrate, erythritol tetranitrate, amyl nitrite, sodium nitrite, and so on. An important pharmacokinetic feature of nitrates is that all nitrates undergo very high first pass metabolism with the exception of isosorbide mononitrate. So nitrates undergo very high first pass metabolism, and this results in less bioavailability. So bioavailability is very less, therefore formulations are available such as sublingual preparations, transdermal patches, ointment, nitroglycerin spray is available, and this helps to bypass the first pass metabolism and enters into the circulation and ensures better bioavailability. The short-acting preparation such as sublingual nitroglycerine is commonly used to abort acute attack of angina. The sublingual preparation is placed below the tongue, which gets absorbed through the oral mucous membrane and enters into the facial vein and the internal jugular vein and finally enters into the blood circulation and is available for action within 1 to 2 minutes. So the onset of action occurs in 1 to 2 minutes and provides prompt relief from the symptoms of angina in 5 minutes. So sublingual nitroglycerine is commonly used for treating an acute attack of angina. Therefore, short-acting preparations are very useful for aborting acute attack of angina, whereas the long-acting preparations such as transdermal patches of angina are used for the prevention or prophylaxis of anginal attacks. So let's now discuss the mechanisms through which the nitrates relieve chest pain or angina. The main mechanism through which the nitrates act is through venodilatation. So at low doses, nitrates predominantly act on the veins, causing dilatation of the veins. This decreases the venous return to the heart, thus decreasing the preload, the end diastolic volume, the end diastolic pressure decreases, the workload on the heart decreases, and this decreases the myocardial oxygen demand on the heart, and this decreases the chest pain and helps to relieve chest pain or angina. So the main mechanism through which the nitrates relieve chest pain is through venodilatation, and this also helps to improve the subendocardial blood flow to the heart, and this further helps to relieve chest pain or angina. The second mechanism through which the nitrates help to relieve chest pain is through its action on the arteries. But do remember that nitroglycerin predominantly acts on the large arteries, the arteries with a diameter of greater than 200 micrometer, with very less or minimal effect on the resistance blood vessel. As we can see in the figure, the subendocardial region of the heart is more prone to injury, and when there is an ischemic injury because of an atheroma which causes narrowing of the blood vessels, and this decreases the blood supply to the heart muscle, to the tissue, causing injury to the subendocardial region. Now, because of decreased blood supply to the subendocardial region, there is hypoxia, and hypoxia causes dilatation of the blood vessels in the ischemic region. So this acts as a compensatory mechanism of the heart to ensure blood supply, to maintain the blood supply to the ischemic tissue. So some amount of blood reaches the ischemic tissue because of dilatation of the resistance blood vessels in the ischemic region. So what happens when nitroglycerin is administered in presence of atherosclerotic narrowing of coronary arteries? Now, nitroglycerin, as we have learned, that it predominantly acts on the larger blood vessels without affecting the resistance blood vessels. So nitroglycerin dilates the large epicardial coronary arteries, and this enhances or facilitates the blood through the blood vessels and opens up the collaterals. So increased blood flow through the collaterals happens, and the blood flow reaches the ischemic region. So the ischemic region, the blood vessels are dilated, the collaterals open up, and the dilatation of the arteries ensures and facilitates the blood flow to the ischemic region. So this happens because of the characteristic feature of nitrates, that is, it causes dilatation of the larger arteries without affecting the resistance blood vessels. This is important because non-selective arterial dilators such as dipyridamole are not used in the treatment of angina. Dipyridamole, unlike nitroglycerin, dilates the resistance blood vessels. So when the resistance blood vessels are dilated in the healthy tissue, the blood flow from the ischemic region gets diverted to the healthy tissue, and this is known as coronary steal phenomenon. So coronary steal phenomenon is seen with dipyridamole. This further aggravates ischemia, this further aggravates hypoxia, which is why dipyridamole is not used in the treatment of angina. Thus, dipyridamole, a non-selective arterial dilator, is not used for the treatment of ischemic pain because it causes dilatation of resistance vessels, and the dilatation of resistant vessels causes diversion of blood from the ischemic region to the healthy region, and this further aggravates the ischemic pain. So the primary mechanism of nitrates is through venodilatation, but it also dilates the large epicardial coronary arteries, thus facilitating the blood flow to the ischemic region and helps to relieve chest pain. The third mechanism through which nitroglycerin helps to relieve chest pain is through inhibition of platelet aggregation. So inhibition of platelet aggregation is further helpful in the management of unstable anginal pain. So now let's see the molecular mechanism through which the nitrates cause relaxation or dilatation of blood vessels. The nitrates release nitric oxide that stimulates guanylyl cyclase enzyme. The guanylyl cyclase enzyme causes conversion of GPP to cyclic GMP, which causes stimulation or activation of phosphatase enzyme. Phosphatase enzyme is responsible for dephosphorylation of the myosin light chain, and this causes relaxation of the smooth muscles. So, speaking about the adverse effects of nitrates, nitrates at low doses causes dilatation of veins, which causes venodilatation and decrease in myocardial oxygen demand on the heart and is the main mechanism for relieving chest pain. At higher doses, nitrates dilate the peripheral arteries, which decreases the peripheral vascular resistance, thus decreasing the blood pressure and causing hypotension as a side effect. Decreased blood pressure causes compensatory activation of sympathetic reflexes, causing tachycardia, which further aggravates angina and increases the workload on the heart. So tachycardia is a side effect of nitrates. Because nitrates cause relaxation and dilatation of blood vessels such as cutaneous blood vessels, it causes flushing and also the cerebral blood vessels are dilated, so headache occurs as a side effect. Nitroglycerine on long-term use causes tolerance as a side effect. What is tolerance? Tolerance means decreased effect over a period of time or higher doses are required to produce the same effect. The underlying mechanism for the development of tolerance is related to the mechanism of action of nitrates. So, the therapeutic effect of nitrates is due to the production of nitric oxide. In nitrate tolerance, there is reduced production of nitric oxide which causes development of tolerance and reduced effect over the period of time. A special type of tolerance which is induced by nitrates is the Monday's disease. In Monday's disease, the workers are exposed to nitroglycerine, which is a component of industrial explosives. Initially, when the workers are exposed to industrial explosives, they experience symptoms of headache, flushing and dizziness, and this is due to the hemodynamic effects of nitrates. But when the exposure occurs for a long period over a period of time, there is development of tolerance and decreased effect of nitrates. So during the weekends, the workers remain away from work and with a gap of 3 to 4 days, there is a nitrate-free interval, and when the workers resume work on Mondays, they once again experience symptoms which shows responsiveness to nitrates. So coming to the uses of nitrates. Nitrates are commonly used for the prevention and treatment of angina. The short-acting preparation such as sublingual nitroglycerine is commonly used to abort acute attack of angina, whereas the long-acting preparations are useful in the prophylaxis of anginal attacks. Intravenous nitroglycerine can be used for the treatment of acute left ventricular failure. Thirdly, nitrates can be used for the treatment of esophageal spasm and biliary colic as they cause relaxation of smooth muscles. The use of amyl nitrite or sodium nitrite has become obsolete nowadays. However, it can be used for the treatment of cyanide toxicity. So let us see how amyl nitrite works. So let's now see how amyl nitrite works in cyanide toxicity. Cytochrome oxidase is an important enzyme that is responsible for aerobic respiration in tissues. Cytochrome oxidase contains iron metal which is essential for its function. Cyanide ions have the property to cause chelation with iron, and this interrupts the functioning of cytochrome oxidase in respiration. So this hinders the respiration process. Now amyl nitrite when administered converts hemoglobin to methemoglobin which has high affinity for cyanides and forms cyan-methemoglobin as a byproduct. So amyl nitrite forms cyan-methemoglobin, and since the cyanide is used up for forming this byproduct, the cytochrome oxidase is spared and respiration is protected. Thus, cyanide toxicity can be treated with amyl nitrite which forms cyan-methemoglobin which can be easily removed from the body with the help of sodium thiosulfate, and cytochrome oxidase function is spared and respiration is protected. So in this way, amyl nitrite can be used for the treatment of cyanide toxicity. So with this we come to the end of this topic. These are my references. Thanks for watching. Please like, share and subscribe.